Thanks very much. So आवाज नहीं आ रही? हेडफोन है कोई दूसरा? तो ये इसमें लगा हुआ, हाँ लग जाएगा इसमें।
इसकी दो पोर्ट नहीं सर, एक पोर्ट है।
इसमें किसी के पास नहीं है और कोई?
ये
ये मेरा ख्याल अभी जी
मास्क ला रही है।
माइक है हाँ ये माइक है हेलो हेलो आर यू लिसनिंग मी just respond are you listening me yes sir okay that's great so that's great so yes thanks very much so today's topic is hypopituitarism. So, what is this? It is a combined deficiency of the anterior pituitary hormones. Clinical presentation is variable and depends upon the underlying lesion and also the pattern of resulting hormone deficiency. Commonest cause is the pituitary macroadenoma. So there is a classification for the pituitary and the hypothalamus. So there are some of them, there are non-functioning tumors. Other, there will be hormone excess. Some there will be hormone deficiency, and some there will be hormone resistance. So it is generally for the pituitary and hypothalamic diseases. Among the non-functioning the tumors, there are pituitary adenomas, craniopharyngiomas, and metastatic tumors from the other sources. In the hormone excess, you get a prolactinoma, acromegaly, Cushing disease, TSS, LS, and feces secreting adenomas. And in the deficiency, then there will be a hypopituitarism, cranial diabetes insipidus. But in the posterior pituitary and hypothalamus, you have a syndrome of inappropriate ADH. And I think Professor Vahisam has described about that already. So what are the causes of the anterior pituitary hormone deficiency? Because it is pituitary deficiency is predominant from the anterior pituitary. Among them, there are structural causes. What are the structural mean which involve the parenchyma of the pituitary? There are the primary pituitary tumors. Among them, adenoma on the top. Then there are the carcinomas. They are exceptionally very rare. Craniopharyngiomas, meningiomas, and secondary tumors, including leukemia and lymphoma. Then germinoma, adenoid cysts, this hemorrhagic as well. So there are some inflammatory conditions as we define normally for any organ. We define the pathogenesis to the infection, inflammation, then tumors, and the congenital or others. So among the inflammatory and this inflammatory in Pakistan, most of the time it will be tuberculosis. You have to have a high suspicion. Then pituitary abscess, encephalitis can present with that. Then sarcoidosis is one of them. Hemochromatosis, Langerhans, histiocytosis, and lymphocytic hypocytitis, all they are included in that. There may be congenital deficiencies where there is gonadotropin relating TRH hormone deficiency, CRH, and growth hormone relating hormone. Then head injury can cause this. The surgery related secondary to head injury can present with that, and that will be paracellular surgery and the paracellular radiotherapy along with the post-mortem necrosis, that is Sheehan syndrome. A lot of question comes about the Sheehan syndrome. So how will you assess that for the, first of all, the first hormone which loses is the growth hormone. So it is earliest to be lost. And in adults, they present with the lethargy, muscle weakness, increased fat, and features are not obvious in isolation. So you have to have a high suspicion because lethargy, muscle weakness, and increased fat, it can come with the hypothyroidism as well, because there will be increased fat production, there will be muscle weakness, there will be lethargy. So you need to have it can present with hypothyroidism and it can present with the growth hormone deficiency. And the second one is the gonadotropin hormone, luteinizing hormone, FSH impaired. They are the impaired in the second. So in that there will be loss of libido in the male, and there will be oligomenorrhea or amenorrhea in the female. So that could be the first presentation in the female. Later in the male, the gynecomastia and decreased frequency of shaving can occur. So there will be hair loss as well. In both sexes, the axillary and pubic hair, they eventually become spare or even absent. Skin become characteristically finer and wrinkled, and chronic anemia will be there. If someone gets the ACH deficiency, then the cortisol deficiency will be there. Patient, they will present with the postural hypotension, and aldosterone in this condition will be normal. So there will be a dilutional hyponatremia. So hyponatremia, so there are loads of causes of hyponatremia in endocrine. They can present with the hypothyroidism as well, with the pituitary disease. I still remember a case in emergency department when I was working as a medical officer, and the surgeons, they asked me, the patient was presented with the upper abdominal pain, lower chest pain, something like that, and they asked me to see a patient, and his sodium level, which I saw at that time, it was 103. And I told my registrar immediately that this patient, he has a very significant hyponatremia and he will be coming on our way, mean he will be admitted under us. So the big suspicion for that was this pituitary tumor. So therefore, these are the dilution hyponatremia is a very significant. If someone has a severe hyponatremia, always think about the pituitary adenoma or something like that. So a striking degree of pallor can be present in that. TSH secretion is lost with the consequent secondary hypothyroidism, apathy, and cold tolerance. Though the frank, what we call it, a mixed edema is very rare. Presumably because of the thyroid retains some autonomous function as well. So how to investigate these patients with the suspected hypothalamus? So normally what we do, you do the pituitary hormone deficiency, identify first of them. Whether it's a ACTH deficiency, is it a LHFS deficiency, or is it a TSH deficiency, or is it a growth hormone deficiency? And you will do this testing. For ACTH deficiency, normally you do this ACTH stimulation test called the synectin test as well. If there is it's abnormal, then you can do the insulin tolerance. And if there is uncertainty in that for the interpretation of short synectin test, you can do that as well. LH and FS deficiency in predominantly, if there is a suspicion of that, you will measure the serum testosterone on LH level, FSH level. And in the perimenopausal, ask if the menses are regular or not. If they are regular, then suspicion is low. But in the if they are irregular, then the suspicion is high. In the post-menopausal women, you will only find it by measuring the serum levels of LH, FSH, and that. If SH is more than 30 international and LH is none, that normally happens in that. TSH deficiency measures serum random T4. TSH is often detectable in secondary hypothyroidism. So here the clue will be that you will be going to measure that serum T4 level, which will give you the clue. So practical points in investigations. If someone is acutely unwell, always diagnose and treat first cortisol deficiency. That is the bottom line. So your first test will be serum cortisol level and the short synectin test, as I mentioned over there. So these will be the first line tests which you will do. Other tests can be undertaken later. Specialized biochemical tests like insulin test, GnRH or TRH are rarely required. Second will be after the biochemical studies, then you are going to do the MRI or CT scan to identify the pituitary or the hypothalamic tumors. If tumors are not identified, there is no tumor, then always look for the infection or the infiltration. Among the infection, the most common cause will be in Pakistan will be tuberculosis, and in the among the infiltrative one, then you have to have a high suspicion of sarcoidosis. And sometimes the vasculitis, they do present with the pituitary tumor. This I will come down later on about this. Uh, uh, about this management. Okay, you can do for the management point of view. For general, these are the general. For thyroid hormone replacement, you are going to give levothyroxine 50 to 150 microgram once daily. It's not like a primary hypothyroidism. So major TSH is not helpful in adjusting the dose in that. But if someone has a primary hypothyroidism, so you measure the TSH. But if someone has a coming from the pituitary or above, then you will not be going to measure TSH. You are going to measure the T4 level, because hypopituitarism also secrete glycoproteins that measured in the TSH assays. So these assays, as you know, in every lecture, I'm saying that there is a different in the interpretation of the assays, because one assay can give can lead to another assay, what we can finding of the other assay in the blood, and which can be a false positive or false negative both. So maintain serum T4 in the upper part of the reference range. So that is the clue. So measure the T4. If it's T4 is low, increase the dose. If T4 is up, reduce the dose. It's dangerous to give the thyroid replacement in the adrenal insufficiency. First, you have to give the glucocorticoid therapy, because if you're not going to give this one, he will be going into adrenal crisis. So for every in the hypopituitarism, so you're first of all replace the cortisone, then replace the other hormonal therapy. So for the sex hormone replacement, gonadotropin deficiencies in women less than under 50, and in the if they are under 50, you are going to replace that. But in the men, you are going to give them to restore the normal sexual function. And both of these, you are giving them for to prevention of the osteoporosis as well. If someone has that, you have to replace the hormone. There is no point to giving the other anti-osteoporosis therapy. So growth hormone replacement, normally it is given by the daily subcutaneous self-injection to the children and adolescents. Uh, they can inject, but because they come in the pen form nowadays, all these injections they are come like the in one. So anyone, the child, you can train them, and the adults they can take the injection by themselves. So normally you discontinue in the children when the epiphysis is fused. There is a full replacement with the hydrocortisone, with the levothyroxine and sex steroid if someone has a hypopituitarism, because the combined therapy has a significant much more beneficial as compared to single replacement. The patient can remain lethargic and unwell compared to the healthy population. So they will be having these residual symptoms. So so uh, you will not be going only about the symptoms as well, because their symptoms can persist. Okay, but you can check the level first. Objective improvement in the fat and muscle ratio will be reduced. Other metabolic parameter will also be improved. And if they are also, and in that situation, you can just manage the growth hormone according to the blood test and the fat muscle ratio and the metabolic. Treatment with growth hormone may help adults to achieve a higher peak bone mineral density. This is the most important, particularly in the female, because there are high chance for the osteoporosis and for the fractures as well. Principal side effect of the growth hormone therapy, they cause sodium retention. So people, they can have a peripheral edema, and they can have a carpal tunnel syndrome. So start the growth hormone at low dose and monitor the response by the insulin growth factor 1. The second among the most common causes are the pituitary tumors. In the pituitary tumors, there are a variety of mass effects depending on their size and the location. That can be an incidental finding on the CT or MRI, like you get the CT or MRI for one thing, and you find that there is some pituitary tumor in that. So in that is called the incident finder. So there are variety of disorders that can present as a mass lesion in around the pituitary gland, and so this can be a hidden, maybe a adenoma, maybe he has a tuberculosis, maybe he has a sarcoidosis, maybe he has a what we call it vagueness. So it can be incidental finding, and it can give you a clue. So intracellular tumors are the pituitary macroadenomas. Most of the time they are non-functioning. So this cellular masses, they are called the craniopharyngiomas, and they are the most common cause of paracellular mass is the meningioma. Clinical assessment of the pituitary tumors. How will you do? So the symptom wise, the most common symptom is the headache, but it is non-specific, as headache occurs in a lot of other conditions. Then the significant among them after the headache is the always look for the bitemporal hemianopia or upper quadrant pneumonia. There will be a loss of acuity or scotoma, and there will be homonomous anemia, no, hemianopia. So visual field defect is the test which you have to do clinically. So any type of visual field defect, if you find it, you need to find out the cause for that, and pituitary is the main differential diagnosis which you have to look for. So if someone comes with a headache, if someone comes with the signs of or symptoms of pituitary, so the clinical test most important will be the visual field defect. You can see on the fundoscopy of the atrophy, and there can be a lateral extension with the cellular mass along with that. Diplopia, double vision, and strabism, then cavernous sinus with the compression of the third, fourth, and sixth cranial nerves. It can cause this. So if you find anything from the third, fourth, and sixth cranial nerve and the visual field defect, so that you can say the devil lies in the pituitary, because with that you will send. So if someone get any venous thrombosis, then you have to have the suspicion along with that with the pituitary disease as well. That include third, fourth, and sixth cranial nerve. Occasionally pituitary tumor, they can be infarct, and it can bleeding can happen in that, and bleeding occurs in mainly in the cystic lesion. So just the bleeding, it can be cystic lesion in anywhere. If someone has a cyst in the liver, if someone has a cyst in the kidneys, so they can bleed as well. And if they can have a cyst in the subarachnoid space or in the brain, they can bleed as well. So anywhere there is a cystic lesion, always think that the bleeding can happen over there. So that is called the pituitary apoplexy. Local compression symptoms and acute onset hypopituitarism occur most commonly when someone has the tumors. So non-hemorrhagic infarcts can occur, particularly there is the condition called Sheehan syndrome, where there will be a catastrophic obstructive hemorrhage, and secondary to hemorrhage there can be a infarction in the anterior pituitary as well. So those patients, they can present later on with the signs and symptoms of the pituitary disease. Diabetes mellitus can cause it, and raised intracranial pressure can cause these symptoms. So these are the symptoms: headache along with the other. So with the bitemporal hemianopia or upper quadrant myopia. So these are the other ones there. So then other there is the hyperprolactinemia and the galactoria. They can ask, they are significantly sometimes raised in the pituitary diseases. So what is hyperprolactin? It is a common abnormality that usually present with the hypogonadism or galactoria, means lactation in the absence of breastfeeding. Drugs, especially dopamine antagonists, which you are giving for any other disease, they are going to increase that, and they will increase the prolactin level. So other causes for that is the pituitary tumors and prolactinomas by directly secreting prolactin as well. So there will be, if anything, compressing the infundibular stalk, that can increase the hyperprolactinemia. And if you interact the tonic inhibitory effect on the hypothalamus, dopamine are over there, so there can be a disconnection, hyperprolactinemia. So these are the causes of the hyperprolactinemia. They can be physiological. Among them, stress or post-seizure. So if someone gets a seizure, has the epileptic fit, and you want to diagnose it, you can get a serum prolactin level. That will give you a clue. In pregnancy, it will raise in lactation, it will be raised. Sleep can give you exercise, and baby crying can give. Then there are the drug induced. Among the drug induced is the dopamine antagonist. Antipsychotic drugs like phenothiazines, butyrophenone, antidepressants, antiemetics, metoclopramide, and domperidone, all these. Then the dopamine depleting that, for example, reserpine, estrogens, oral contraceptive pills, and methyl dopa. Then pathologically, there can be a disconnection hyperprolactinemia, where there will be non-functioning pituitary adenoma and usually microadenoma. So prolactinoma is very high in the microadenoma as well. Primary hypothyroidism, polycystic ovaries, and macroprolactinemia, they all can give to lead that. Pituitary tumors, which are secreting prolactin and growth hormone, they can cause this one. Hypothalamic diseases and renal failure, all these are the causes of. So there is a huge list of hyperprolactinemia. So what is macroprolactin or macroprolactinemia? Macroprolactin, they are the increased prolactin level. So macroprolactin cannot cross the blood vessel wall, so they cannot reach to the prolactin receptors in the target tissue, so there is no pathological significance. Some assays do not distinguish prolactin from the macroprolactin. Macroprolactinemia is the prolactin level in the blood. It is a cause of spurious prolactinemia. Identification requires gel filtration, chromatography, or polyethylene glycol precipitation. And if prolactinism is not known to cross-check, is known to cross-check these tests, you should have to perform all this on these specialist assays. So prolactin usually circulates as a free monomeric hormone in the plasma. In some individuals, it becomes bound to the IgG antibodies. Complex is known as macroprolactin, and some patients have macroprolactin. Not to be confused with prolactinoma, that is a tumor, prolactin secreting tumor. So prolactinoma is different, and prolactinemia is the macroprolactinemia is different. So you need to differentiate between them. So clinical assessment, what will you do? You will find you will find out for the galactoria, you will find the hypogonadism associated with the prolactinemia. So there, what will be the symptom for the hyperprolactinemia? There will be secondary amenorrhea, ovulation and infertility, drug use, recent history, menstrual history. In men, there will be a decreased libido, reduced shaving frequency, lethargy. So these will be given. So unilateral galactoria may be confused with the nipple discharge, breast examination to exclude the malignancy, hypertrophic changes. So you have to do these tests clinically. So investigation, first rule out pregnancy. If pregnancy is ruled out, then you will check the serum prolactin. It's approximately 500 milli international unit per 25 for 4 nanogram per of the upper normal limit. So if the level is between 500 to 1000, always think about the stress or the drugs, and the repeat measurement is necessary. If someone has a between 100 and 500, then think about the microprolactinemia or disconnection hyperprolactinemia. If the level becomes 5000, then there will be a macroprolactinoma. So that will be a tumor. So check for the gonadal function for the T4 and the TSH to exclude primary hypothyroidism causing TRH-induced prolactin excess. So if prolactin above the reference range, then you will, and there is a biomarker, then clinical suspicion, always do the MRI or CT of the hypothalamus and the pituitary, and the macroadenoma test for the hypopituitarism. You will do CTM or MRI. Some lesion can give a distinctive neuroradiological features, but the definite diagnosis is made on the histology. So there is, so MRI the features some are suggested, but you cannot find them. So what are the therapeutic options normally for the pituitary or hypothalamic tumors? So it depends upon whether you have prolactinoma, whether you have acromegaly, whether you have a Cushing disease. I think I will come back later on about this uh, over this one. So these are the drugs which normally always look for the. I think this slide is coming next. Uh, just a minute. Uh, So I will give a little bit of this the management formula. First of all, anyone who is coming with the pituitary hypopituitarism, always think about the evidence of pressure on the visual pathway. If it is there, then do the urgent treatment. Full recovery is unlikely if the symptoms are longer than 4 months. If there is a serum this cellular mass over there, serum prolactin is measured before emergency surgery. If prolactin is over 500,000, then think about macroprolactinemia. Then you have to give, before you have to give the surgery, you have to start the patient on dopamine agonist before the surgery, so that the tumor can be shrunken, and then surgery will be having much more benefit. If it's not, maybe sometimes that you do not need to go for the surgery. So for the surgical approaches, normally for that is the transsephinidal approach via nostrils, and there is a transfrontal surgery via craniopharyngiomas. But they are reserved for the supracellular tumors, unable to resect through the lateral extensions into the cavernous sinus. All operations on the pituitary, they carry a high risk of damaging normal endocrine function, so the risk increases with the size of the pituitary lesion. Pituitary function should be restored 4 to 6 weeks following surgery. If not, then think about the other causes. So always check the hormone, that where is there any development of new abnormal hormone deficit or in that. So that's the only way to check. Usually repeat imaging after 3 to 6 months. Significant residual mass and histology confirm that anterior pituitary tumor, and in that you can go for the external radiotherapy. Radiotherapy not useful as an urgent measure, take many months or years to be effective, and there is a risk of acute swelling of the mass. So there is a functional radiotherapy which have a 50 to 60% in the hypopituitarism, but it takes longer times. So the side effects, they are the cognitive function decline, vascular changes, and it can induce primary brain tumors in the head as well. So there is now, as the radiosurgery and the radiotherapy, they have advanced nowadays. So there is a term called stereotactic radiosurgery for residual disease in more focused fashion, and though these things is available only in the specialized centers. So for the non-functioning tumors, repeat imaging at intervals, smaller lesion with no mass effect, the therapy may not be indicated. Monitor by serial neuroimaging without a clear-cut diagnosis. So in among the once it is you can replace if someone gets a hypothyroid, replace the thyroxine as well. This I will come back later on. So what is prolactinoma? The other cause of that. Prolactinoma is the perimenopausal woman with microadenoma because the symptom of prolactin excess usually results in early presentation. There is a prolactin secreting cells. They share a common lineage with the growth secreting hormone. So if someone has a growth secreting hormone, so he can found a excess growth hormone deficiency, and that can cause acromegaly as well. If someone has acromegaly, then you have to check the which assay by which it is doing, and check the serum prolactin level. This lecture will be about the acromegaly, will be given by next week, I think, by Isab or someone else. So prolactin, there is a relationship between the prolactin concentration and the in the tumor size. Some macroprolactin can elevate prolactin about 100,000. So in that, always investigate for the pituitary tumors. So medical therapy for that is dopamine agonist drugs, which are as the first line agent. They reduce serum prolactin concentration and cause significant tumor shrinkage after several months of therapy. Visual field defects, if they are present, will improve within days of the first administration. So once you start, so clinically you can assess the patient, you start the patient on that, see in your clinic and see the visual field defect. So if that is improving, it means patient is going in the wrong direction. So continue that. Withdrawal of dopamine and can occur after a few years in macroadenoma, but in macroadenomas, drug can be withdrawal only after curative surgery or radiotherapy, and that should be under close supervision. So what are the other which we are doing dopamine agonists? They are the bromocriptine and cabergoline, can bind to 5-HT2B receptors in the heart. They can cause fibrotic reactions in the valves, and predominantly it causes in the tricuspid valve that give you a regurgitation. And there is a high incidence in patients with the Parkinson disease who got the dopamine agonist, because we give this treatment for the Parkinson so they can get tricuspid regurgitation. But at low dose, screening with the echocardiogram is enough, and we do not need to hold the treatment. Surgery for the and radiotherapy for the macroprolactin or microprolactin, as I mentioned early on. So the dopamine agonist therapy is for the macroprolactinoma. If failed, then surgical decompression. So there is a significant cystic component which can lead to bleeding, and they will be intolerant to the dopamine agonist. But microadenoma will be by transaphenidal surgery. Cure rate is about 80%. Recurrence is possible, but cure rate for macroadenoma for the surgery is sometime is very much lower. So in that you will go for the dopamine therapy. External radiation may be required for some macroadenoma to prevent regrowth if a dopamine agonists are not strong. So what happens in the pregnancy? In pregnancy, hyperprolactinemia often presents with the infertility, but sometimes they can have a high, as you know that there will be raised prolactin in pregnancy, but they can present with the hyperprolactinemia. So in that, dopamine agonist therapy will be used following the pregnancy. Hello, hello, any problem, any problem, just text me please. Hassan, any problem? Hassan, Ali, Mohsin, Adnan, Aslam, anyone, write it down. That's great. Okay, thanks very much. Thanks very much. So there can be a microadenoma or macroadenoma. So in that microadenoma, they will be withdraw dopamine agonist as soon as pregnancy is confirmed. Okay, because that will be having some benefit. But macroadenoma may enlarge rapidly during estrogen stimulation and continue dopamine therapy in that. So depending upon that, you will keep the treatment simple. So major prolactin level and visual field during pregnancy, and advised to get report headache or visual disturbance if they are present. So they can occur in the pregnancy, and in that the treatment will be different. So what are the drugs used for the to treat the prolactin? They are the bromocriptine, cabergoline, quinaglide. So bromocriptine is 2.5 to 15 milligram. It is available for parenteral use, shorter half-life, useful in treating infertility and preventing long-term efficacy. Sorry, proven long-term efficacy. Disadvantages are that they can get nausea, headache, postural hypotension, constipation. So these are the features. Cabergoline, it is, you will be studying these drugs uh, a lot when you will be in the training phase, because they are the dopamine agonists. They are used in the Parkinson's disease as well. So there is a this cabergoline as well. It's a famous drug. It's given. It is long acting. So missed doses less important. Reported to have few side effects, and it has a limited data safety in the pregnancy, associated with cardiac fibrosis and in the Parkinson's disease. As I mentioned early on, so these are depending upon the condition whether he has in the pregnancy or not. You will choose your drug. Quinaglide, it has a limited data safety on the pregnancy. So in the pregnancy, bromocriptine or this one is the better as compared to the other one. Now the third one will be the craniopharyngiomas. So how they will be presenting, and what will be the treatment option for that. So craniopharyngiomas, they are the benign tumors of the rest of the Reckitt's pouch, may be located with the sella turcica or suprasellar space, often cystic with the solid component that may or may not be calcified. In young people diagnosed more commonly than pituitary adenomas, may present with pressure effect on the adjacent surface, and hypopituitarism or cranial diabetes in spiders can occur. So in it, so the features they are in the commonly as compared to this pituitary adenoma, pressure effect will be significant on the adjacent structure, and there will be more incidence of cranial diabetes in spiders or hypopituitarism. But if they are acting on the hypothalamus, there will be hyperphagia, there will be opacity, there will be loss of sensation of thirst, disturbance of temperature regulation, as hypothalamus is involved in these functions. So if someone gets the symptoms of hypothalamic, then it means that it will be affecting over there rather than the pituitary itself. Can be a significant clinical challenge to manage. So it will be very difficult to manage those patients. So what are the treatments for that? Treatment is the again the surgery. So it is normally it's the transiphinidal approach is reserved for the craniopharyngiomas. But craniotomy which can be done if someone has a very high risk of hypothalamic damage and other complications. If there is a cyst or cystic cavity in that, then you will go for the surgery, because you can drain a large cystic component and by the external shunts, and that can save the surgery. Whatever form it takes, surgery is unlikely to be curative. So even you are doing the surgery, there are indications for the surgery, but the risk they are high and they cannot be well cured. Radiotherapy may often be given to reduce the risk of relapse, but that will be after the surgery. So nowadays there are a lot of modes of giving the radiotherapy, and particularly in the brain, there are very fine what we call it instruments by which they give the selective radiotherapy at the particular site. Craniopharyngiomas often recur, requiring repeated surgery, often cause considerable morbidity, usually from hypothalamic obesity. They can water balance problem will be there, and visual failure can be permanently over there. So these are the side effects for the craniopharyngeal pharyngeal treatments. Now, few slide I'm going to give you about the test, and that will be how to do the insulin tolerance test to diagnose for that. So in how to do it, it's normally used as the uses are the assessment for the hypothalamic pituitary axis and assessment of the growth hormone deficiency. For that, you confirm that you are going to do that. Indicated when there is a doubt about the other test is usually performed in the specialist centers, especially in children. IV glucose and hydrocortisone must be available for resuscitation because the patient, when you are doing the insulin you are giving the insulin repeatedly, and the patient they go into hypoglycemia and they go into the hypoglycemic shock and they can have a mortality. So contraindications, they are ischemic heart disease. Also, if someone has the ischemic heart disease, you are not going to do the insulin tolerance test or insulin stress test, it is called as well. So other is the epilepsy. If someone has the epilepsy, you are not going to do that. If someone has a severe hypopituitarism, for example, his 8 a.m. serum cortisol is less than 180 nanomole, so you are not going. The dose which you give normally is 0.15 unit per kg body weight soluble insulin IV. The aim is to produce adequate hypoglycemia, mean there should be tachycardia, sweating with the blood glucose less than 2.2 millimole or 40 milligram per deciliter. Blood sample you are going to do 0 at time 0, then at after 30 minutes, at 45 minutes, then 60 minutes, 90 minutes, 120 minutes. You are going to check the blood glucose, you are going to check plasma cortisol, and you are going to get growth hormones. So how will you interpret the results? Normal subjective growth hormone is more than 6.7. The precise cutoff figure for cortisol and depends on the assay used in that. Normal subject is the, I think that the slide is, I will just go to the, I will just show, I will, so normal subject will be having the, what we call it, sorry, no, that's okay. So, so normal will be growth hormone more than 6.7. So if normal subject cortisol more than 550, approximately 20, so then the test is negative. But if they are there, then the test will be positive. So what are the other tests for the growth hormone secretion? They are commonly growth hormone. They are undetected, so a choice for the range of stimulation test is required. So insulin-induced hypoglycemia, serum arginine level, we combine with HRH, glucagon, and clonidine in the children. You can do these tests for the diagnosis of the growth hormone secretion. So growth hormone deficiency, what causes this? When someone has the growth hormone deficiency, only investigate if growth hormone replacement therapy is being contemplated. Measure immediately after exercise. Consider other stimulatory tests. If someone has a diabetes insipidus, only investigate if patient complains of polyuria or polydipsia, which may be masked by the ACET or TSH deficiency. Exclude other causes of polyuria with blood glucose, potassium, and calcium measurements. Water deprivation test of 5% saline infusion is used for the for the cranial diabetes insipidus. Identify hormone excess, for example, measure serum random prolactin level, investigate for acromegaly or Cushing syndrome if they are clinical features, establish the anatomy, consider the visual field testing and the imaging the pituitary and hypothalamus for the the MRI. So here is some of the, I know that you have gone through this one, how to interpret the diabetes insipidus or from the cranial or this one. So it has the protocol as well, which you do it. It's a slide just to mention about the about the this test. So it will be on your that. I'm not going into detail because uh, Professor Vahisam has already given you the lecture. So this was the slide which I made it extra for that. So any question? So now the question will come up. So any questions now? So no more, no questions. Very good, excellent. So if I will go back to few of the slide, if you don't have the questions, okay. One of the slide will be which I haven't described. What are the therapeutic modalities for the functioning and the non-functioning hypothalamic and pituitary tumors? So there are so this is a slide which is in your book as well. So if someone has a non-functioning pituitary macroadenoma, so the surgery will be first line and radiotherapy will be second line. If someone has the prolactinoma, then the first line will be dopamine agonist. Second line will be radiotherapy or the surgery. And dopamine agonist usually cause macroadenoma to shrink. But if someone gets acromegaly, then the first line will be the surgery, and second line will be somatostatin analog, dopamine agonist, and growth hormone receptor agonist. Medical therapy does not really cause macroadenoma to shrink. For radiotherapy and medical are used in combination for inoperable tumors. So this is in the case of acromegaly. But if someone has a Cushing disease as well, so then the surgery is the first line. Second line will be steroidogenesis inhibitor, that is called paclitaxel. Its radiotherapy can take many years to reduce ACH excess, and medical therapy may be used as a bridge therapy. What is bridge therapy? Bridge therapy is which we normally use for the other that someone is not fit for a surgery, someone has the other comorbidities, and in that you can use the medical therapy to put a bridge between the disease and the surgery. So bridge therapy is used in a lot of conditions where the patient, for example, they are on the waiting list, they do not have we do not have the main specialized center. So in that we start the patient on that, and we refer the patient to the specialized centers or uh, treat the other comorbidities. So it means it will be during the waiting period or the window period. In that time you are going to give the what we call it bridge therapy. So bilateral adenopathy may also be considered if the pituitary tumor is not completely resectable. So in that situation, so you will have to do the adenalectomy. But the problem with that is you have to give the after adenalectomy you have to patient will going to get Addison disease. You will have to replace the what we call it cortisone as well and the mineralocorticoid both. If someone is getting the pituitary surgery, you and in that situation we may need to give the what we call it cortisol, but we do not need to give the mineralocorticoid therapy. So that is the difference between if you treat the patient at the adrenal level or if you treat the patient on the hypothalamic or pituitary level. So this is the question. This is your choice of treatment depending upon the whether he has a prolactinoma, whether he has acromegaly, whether he has a Cushing disease, or he has a non-functioning pituitary macroadenoma. I think the, No, that's all. Everything. So if you have the time now, I can go into the interpretation of the how to do this what we call it, the test for the diabetes insipidus. Okay. So what we will do in that, the protocol is, do not ask him to take coffee, tea, or smoking on the day of the test. Give him free fluid at 7:30 in the morning of the test, but discourage the patient from stocking up with extra fluid in the anticipation of the deprivation. No fluid from 7:30. Before that, he can take the fluid, whatever. Attend at 30. He will come down, measure the body weight, plasma, and urine osmolality. Record body weight, urine volume, urine and plasma osmolality, and third score on a visual analysis every 2 hours for up to 8 hours. So these endocrine tests. They are very long standing, like the immunology, skin testing, or testing challenge. So these are because it takes a full day to do these tests. Stop the test if patient lose the 3% of the body weight. If plasma osmolality reaches more than 300 and urine osmolality is less than 600 ml, then administrator DDVAP 2 microgram intravenous. Well, how will you interpret that? Like now, in short, take fluid until 7:30, no fluid after 7:30, present at 8:30, measure the body weights, urine and serum osmolality, then measure the body weight, urine volume, urine osmo and plasma osmolality every 2 hours for up to 8 hours. So if patient loses 3% of body weight, stop the test. If plasma osmolality reach more than 300 and urine less than 600, then give DDVAP. So if plasma after given the DDVAP, plasma diabetes insipidus is confirmed if someone has a plasma osmolality of more than 300 milliosmol and urine osmolality less than 300. Now you want to find out the cause, whether it's a cranial or the nephrogenic. If someone has a cranial diabetes, my urine osmolality rises by at least 50% with the DDVAP. But nephrogenic diabetes insipidus does not concentrate the urine. So urine osmolality, if it's increased, it means he has a cranial diabetes mellitus. If it does not increase, then he has a nephrogenic diabetes. So if it is remains low, then the primary polydipsia at the start of the test. So that is the interpretation of the this cranial or in this diabetes mellitus, diabetes insipidus, to differentiate between the cranial and the what we call it, uh, nephrogenic insipidus. So any question again? Are you there? So Muhammad Sufyan. So how was the result? Last result, pulmonology result. So you don't have any question to ask today, is it? अभी नहीं आया result. Okay, that's okay. Okay, that's okay. So can you not check it on the Moodle? Can you not check it on the Moodle? Moodle पे आ गया Arishma, very good. So Moodle पे आ गया. So you have checked that. So how is it? So are you looking forward to come to the college? Or you're happy to stay over there? घर पे खुश रमजान के बाद okay that's okay so no that's okay रमजान के बाद yes but it's not too hot at the moment the weather is not too hot it's not as hot as its previous years so any question no okay so if there is no more question because we are looking we are keeping an eye who are asking the questions and who are not asking the questions Mahnur but Ijaz Hussain Bilal Khalid Adnan Aslam Ali Mohsin so there are nearly 140 participants over there and you haven't asked even a single question that's great raise hand if you have any question okay so thanks very much uh, so we will finish the lecture I will go away okay thanks so I will leave the meeting now is that okay respond me if you want to leave the meeting Fahad Ahmed so he is happy to if I go away so he is very anxious to to leave the place so Sufyan no sir please stay okay Talha Siddiq so how is the situation of COVID on your place anyone so 19 news are they true positive or the false positive how many are the false positive in that Talha excellent so is there any new case in your area बहावलपुर में सुकून है अभी अहमद नवाज that's great very good anyone from other cities from so that's good that in your area so yeah please stay safe because there is no collateral support there is no health support at all in our country so for the particularly for the sick patients okay that's great thanks a lot I will head off now and